in 2014, we analyzed our data for the whole year, and we found out that not a single patient with 40% total body surface area burn survived. Burns is being treated as an orphan child of surgery. Surgery used to be an orphan child of
public health
or general health care. Now the same orphan child is now having another orphan child burn care. In the US, they can save patients up to 98% burn, which means the only part of the body which is not burnt is the area covered by their two palm areas. I was operating 1 day a week, and that there were so many burn patients, and there were so many cleft patients, post-burn contracture, congenital deformities, trauma. There was no way I could finish those cases. Any surgeon who wanted to work with our team, I would never say no to them. Many times I knew that surgeon would not be knowledgeable or skillful in the beginning. It did not matter to me because I knew if we trained them adequately, they would be as good, if not better surgeons than myself. There are many surgeons who are much, much better than me, especially cleft surgeons now. How do I know that? Because we invite a lot of international people, including cleft surgeons from all over the world. A lot of people think that, oh, Shankar Rai is great because, he did all these things pro bono. No. Even today, at the age of 70, I'm getting salary. Today in Kathmandu, among the doctors who are performing cosmetic surgery, probably only about 5% of those procedures are being performed by the plastic surgeons.
Hello everyone, and welcome back to a new episode of our podcast series We Dissect. If you are listening to us for the first time, in this podcast series we aim to explore the depth and breadth of surgery, meaning that we invite the surgical leaders and pioneers from each surgical specialties, both nationally and internationally, and from their insight, experiences, and having an honest conversation with them, we try to explore what the field is from inside out. And it's mostly targeted for the undergraduate and even postgraduate medical students who are aiming to explore their path in surgery. And today we have a very special guest. You must have heard of Kirtipur Hospital and all the great work it has been doing for the burn patients. And today we have a very renowned plastic surgeon from Nepal, who along with his team has performed more than 30,000 cleft lip and palate surgeries, not just in Nepal but internationally as well. And he has been trained in different settings within Nepal and internationally as well, which we are aiming to dissect more in this conversation with him. And for all the work he has done nationally as well as internationally, for the burn patients, for the pediatric cleft lip and palate patients, and disadvantaged people from the Nepal and globally, he has received numerous accolades. A few of them which I would like to mention personally is 2004 American Medical Association Nathan R. Davis Award for International Medicine and Public Health. Likewise, in 2005 World of Children Award, and in 2009 Unsung Heroes of Compassion Award by His Holiness Dalai Lama. So a lot of accolades, a lot of experience, and a very inspiring person who we look up to being in the coming days. And without any dues, I would like to welcome our guest for today. He is Professor Dr. Shankar Man Rai, sir. Namaste, sir.
Namaste.
Thank you for accepting our invitation, sir, and joining us.
It's my pleasure to be here.
सर किनकि हाम्रो अडियन्स चाहिँ एकदम ब्रोड हुनुहुन्छ, उहाँहरूलाई प्लास्टिक सर्जरी स्पेसलिटीकै बारेमा अलिक कम्प्लिट नलेज हुनसक्छ, नहुनसक्छ, त्यसको बारेमा हजुरले भनिदिनु न.
प्लास्टिक सर्जरी भनेको चाहिँ नि it's obviously a surgical specialty. You can call it subspecialty as well, because many of the plastic surgeons have already been general surgeons and then they move on to plastic surgery. So we call it subspecialty. But at the same time, it's much more general than general surgery, in the sense that these days, many of the general surgeons, they perform very limited number of surgeries because, for example, there are surgeons who are specialized in colorectal surgery, hepatobiliary surgery, or other, specific fields of surgery, general surgery, whereas plastic surgery, as plastic surgeons, we operate from head to toe. Any pathology, and not just limited to congenital or trauma. We do infection as well as tumors, cancer, reconstruction. At the same time, it's not limited to any gender or age-specific kind of, pathologies. So it's much more general, I would say. As a plastic surgeon, you'll be doing many more general surgical conditions, taking care of them, than a general surgeon. So I call it a general surgery of subspecialty. So it's an interesting field in the sense that you'll be, in one moment, you'll be repairing a cleft lip and cleft palate. At the same time, next time you may be doing completely different kind of pathology. For example, reconstructing somebody's tongue or oral cavity, or even breast, for example, a breast that has been lost due to cancer surgery. You can reconstruct a breast for the lady. At the same time, you may be doing reconstruction of hypospadias, a congenital deformity. Similarly, in hand surgery, for example, there are so many different pathologies and conditions that we deal with. So from there to burns and pressure sores, name any pathology or any region of the body, we will be dealing with that. So I find it very interesting in that sense, because you are not limited to one pathology or one age group or one gender, or one anatomical region of the body, but it's such a general thing. Yeah. If you enjoy doing surgery, probably this is the specialty you have to go to.
Sir, हाम्रो internship मा पनि हामीले सुनेको कुरा हो कि plastic surgeon they deal with people from every ages, from head to toe.
Right.
And seeing a diversity of cases plastic surgery deals with, it looks interesting पनि. But at the same time, you have to be expert in all those cases. Right. So how difficult is it to gain mastery in all this?
No, it's not difficult in the sense that the training is very long, right? I mean, you could do general surgery first, and then you move on to plastic surgery. That's one way of doing it. Another is there are several programs in the world where you can straightway join a plastic surgery program, but you may spend a year or two doing general surgery, getting some ideas about the general surgery. But there are a lot of things that you have to, I would not say unlearn, but at the same time you have to modify what you have learned as a general surgeon, because there are many things that we criticize general surgical procedures when you start learning to become a plastic surgeon. So it's a long process to become a plastic surgeon. So because of the time that you have spent training yourself to become a plastic surgeon, you learn those things naturally. You don't have to stress yourself to learn or to delve into the specialty. It's a slow process. So whenever you are, it's not like marathon, okay? You have to finish so many miles within shortest time. It's not like that. It's a process where you dedicate yourself for a long time. And during that process, most of the programs will let you have experience with different professors, okay, and many times it doesn't have to be limited in one hospital or two. Your training, it could be very international, especially because these days, there are a lot of international teachers who come to your place, or you are sent to so many different international centers where you learn, interact, develop, your networking with a lot of international people. So I would say plastic surgery training has become very international. So you would not feel any pressure or pain to become a good plastic surgeon. You will enjoy becoming a plastic surgeon. The training itself is very enjoyable, I would say.
So what are the common pathologies or conditions a plastic surgeon in context of Nepal deals with?
Yeah, that's a very good question, because you can become a very good plastic surgeon in the US, but you may not be very useful in a situation like ours. In Nepal, being a underdeveloped country, we have a lot of patients who have sequelae of burn injury in terms of post-burn contracture. We had a small study which showed that on an average, our Nepalese people were waiting for 18 years from the time of the injury to the time of the reconstruction. 18 years of waiting. That's probably the longest duration of waiting to be operated by a plastic surgeon in the whole world. I don't know the situation in Africa because I have very short experience in Africa, but I can say that 18 years of waiting just for the reconstruction of burns is too much. And then the other common conditions in Nepal are obviously congenital deformities like cleft, facial cleft, and then congenital conditions of the hand, congenital condition of the ear, and then the congenital condition of the penis, hypospadias in that for that matter. So, and then we also have a lot of trauma because of the road traffic accidents, which is the commonest kind of trauma in Nepal, as you know. So there are opportunities to do a lot of reconstruction post-trauma as well as post-cancer, oncological surgeries for reconstruction. So you can probably divide the whole specialty of plastic surgery into reconstructive plastic surgery as opposed to cosmetic or aesthetic surgery. The aesthetic surgery is coming up very fast because of the media, obviously, and then the paying capacity of many people have, especially the media has given the opportunity for people to understand what cosmetic surgery is, and then there are several centers where you can perform cosmetic surgery for those people who want. But at the same time, there are a lot of poor people who need acute burn care, post-burn contracture reconstruction, post-trauma, post-infective, post-cancer reconstruction. At the same time, you have a lot of trauma patients as well who need reconstructive surgery. So those are probably the commonest kind of conditions. I should not forget bed sores, pressure sores. Those are also very common because there are so many people who are paraplegic and they're bedridden in the beginning, and then they're wheelchair bound, and if they're not trained adequately, they're going to develop pressure sores for sure. Many of the patients who have already undergone surgery also come back with pressure sores since we have not been able to teach them or train them properly to prevent those sores. So these are the common conditions, I would say, in Nepal.
Yeah, sir. I think it brings me back to earlier thing because we told that plastic surgery operates across all ages, but like you said, it operates across all socioeconomic strata as well.
Right.
The people who get burnt and some people who want cosmetic surgery, they fall into different socioeconomic strata. And if you see the effect of this cosmetic plastic surgery, has it been motivating younger people or younger surgeons to take a plastic surgery, or how has it contributed to the plastic surgery specialty?
Yes, I think there are several people, young people, who are attracted to plastic surgery because of the cosmetic aspect of it. But at the same time, when they come to our hospital and see poor patients suffering from conditions like burns and other congenital deformities and having difficulty paying for the service, they get discouraged to go to plastic surgery. I remember a few people, young people, who came to see whether they would enjoy plastic surgery or not. And, some of them don't even last one day when they see the kind of patients that we take care of. So it is difficult for many young people if they just want to do cosmetic surgery. But if somebody wants to do only cosmetic surgery, you don't have to become a plastic surgeon, because becoming a plastic surgeon is a long way. If you want to do cosmetic surgery, you can do dermatology or ENT, which are only 3 years kind of program, and you can do fellowship for 6 months or a few months, and then you can do all those cosmetic procedures, in your private practice. So if you want to become a plastic surgeon, obviously you are entitled to do all kinds of plastic surgery, but at the same time, if somebody wants to focus their practice only in cosmetic surgery, you don't have to become a plastic surgeon. If you are a plastic surgeon, well and good, but I can tell you today in Kathmandu, among the doctors who are performing cosmetic surgery, cosmetic kind of procedures, probably only about 5% of those procedures are being performed by the plastic surgeons. So most of them are being performed by dermatologists, ENT surgeons, and even gynecologists, for example. So it depends on what is your choice. What do you want to do? If you just want to focus on cosmetic surgery, then there are other ways which are much shorter. Do you understand what I mean? Yeah.
Sir, how is your practice of plastic surgery and how has it been evolving?
It's an interesting question for me because when I became a plastic surgeon, most of my work was around cleft lip and cleft palate and post-bone contracture reconstruction. I did hand surgery as well, nothing complicated, but hand surgery. I did some other kind of reconstructive surgery like pressure sores and trauma, infection. But later on, for the last almost 10 years or 12 years, I'm focusing more on developing acute burn care service because I found that this is the most neglected area of plastic surgery or even surgery in general. And in fact, I must tell you that there was a time, long time ago, 1980s, when Halfdan Mahler was the Director General of WHO. He was very much focused on primary healthcare, He's the one who started doing this, health for all kind of movement long time ago. What happened was at that time, it was so difficult to focus on any surgical care because there were so many patients who needed basic health care at that time, all over the world. So he himself said that we need to provide the surgical care also, but because of our situation right now, we are not in a position to provide the surgical care like we should be providing the primary health care. That's what he said. And so at that time, he himself said that surgery is, not himself, but the surgeons later on said that surgery was a kind of, an orphan child of healthcare in general. Because surgery was neglected at that time. I'm talking about the global scale, okay? Not in one country or two, a global scale. Now, surgery has developed. A lot of governments, even, the countries which are poor or middle income countries, these countries' ministries have started paying a lot of attention to develop surgical care. Now, surgeries are provided even in the district hospital. As you know, even in Nepal, there are many district hospitals where surgical care is provided, especially the emergency kind of care, right? But even today, burns, which is also a surgical care, has been neglected all over the developing world, low and middle income countries. Now, so I call all these, the surgical colleagues that I tell them that right now, burns is being treated as an orphan child of surgery. Surgery used to be an orphan child of
public health
or general health care. Now, the same orphan child, long time ago, surgery, is now having another orphan child, burn care. That's how I look at it. So I think burn is very, very neglected, not only in Nepal, but in all over the poor and middle-income countries.
So since you have been working for almost 3 decades and more in this burn surgery especially, how have you seen the field, especially burn surgeries, evolving?
I think we have come a long way because I remember my days when I used to take care of my burn patients at the university teaching hospital. The ward was smelly. None of the other specialists would like to come inside the room because sometimes there were like, gynecological patients who needed the burn patients with gynecological conditions, and then we had to invite gynecologists and obstetricians, and they would not like to come inside the burn room. Similarly, other specialties, it was smelly. We didn't know how to take care of them. We didn't have any specialized kind of care, specialized operating room or ICU for the burn patients. Our knowledge and skill was very limited at that time. But now we have focused on the burn care in such a way that we have also developed a cadre of doctors, nurses, therapists, critical care specialists taking care of the burn patients. So it is now much more kind of advanced compared to what the situation was about 30 years ago. But I will tell you, even within a short period, for example, when we started our burn unit at Kirtipur Hospital in 2014, we analyzed our data for the whole year at the end of 2014, and we found out that not a single patient with 40% total body surface area burn survived. Not a single patient. Okay, and then we started looking at the international, papers, statistics, and then we found out that it is the same kind of outcome in all the poor and middle-income countries, except in few centers where there were dedicated, team trying to improve the burn care. Otherwise, it was exactly the same. The reason were multiples. Once somebody has 40% total body surface area burn, the whole body is affected. All systems like your cardiovascular system, your renal, pulmonary, GI, even your central nervous system, your immune system, every system is affected by the major burn, number one. Number two, the immunity is shut down basically. So much so that if you transplant skin from another person, they cannot reject. It will be taken as if it belongs to them. And then the other thing is the patients, once they have 40% total body surface area burn, they do not have enough skin left in their body to be harvested, to be transplanted to the area to cover the wound. So that was the situation. And then today, after after 10 years, 12 years of our, hard work with blood, sweat, and tears, now we have been able to save 50% of those patients with 40% burn. It took us almost 10 years to bring that change. But if you compare that data with what is happening in the US, it's nothing. We're happy that we're able to save 50% of the patients with 40% burn in 10 years' time. But in the US today, as we speak, they can save 50% of the patients with 92% total body surface area burn. They can save patients up to 98% burn, which means the only part of the body which is not burnt is the area covered by their two palm areas. That's the only area not burned. I can go even further, and that is, in case of the children, pediatric burns, they can save patients even when they have 100% burn, but the 100% should not be third-degree burn. Do you understand what I mean? They have 100% burn, but not 100% is third-degree burn. They still have some areas which are second-degree burn. 98% burn. In the children, they can save almost everybody. If you talk to the pediatric burn surgeons, and if you ask them, when was the time when you lost the last patient with burns? They have to think. They have to go like this. Oh, yeah, maybe 10 years ago, 12 years ago. That's how they express, So these days, any pediatric patients, if they are not 100% deep, 100% third-degree burn, almost all of them are saved. Let me tell you another story.
Sure, sir.
Most of the surgeons taking care of the adult, burns, taking care of adult patients, they think whenever they have a patient like 95% burn, they think whether they should save this patient or not. The question that comes to their mind is, should I be saving this patient? Because the quality of the life after saving this patient with 95% burn, the quality of life is very poor. So they always ask that question. It's not that they cannot save this patient, okay? And the question that comes to our mind automatically is when we see a patient with 40% burn, our question is, how are we going to save this patient? That's the question that comes to our mind. It's a totally different kind of thinking process, the mindset, I would say, thinking process that goes in our head and in their head. The reason is it's not because we are less knowledgeable. Maybe there are areas where we know less, or experience-wise, we take care of more patients, actually. But the gap is because of the access to technology. There are technologies that they have access to. They don't even have to think of the cost, for example. Any technology that is available in the world, anywhere in the world, they can access that resource. Whereas here, we have difficulty accessing those technologies because those technologies are very, very expensive. I call it prohibitively expensive. So that separates the treatment in the developing countries like ours and the treatment in the developed countries where they don't have to think anything. There was one burn specialist from UK, Chelmsford. Chelmsford is very popular for having a very high standard of burn care, and this particular person was the person responsible for making that center an excellent center, right? So he came to our center, and then when he went back after his visit here, he spoke to the local newspaper, and then he sent me a copy. And the first sentence that he had said was, "I am so lucky to be working in the UK where our NHS, the National Health Service, takes care of all the burn patients without any out-of-pocket expenses on the patient's part. I just came back from Nepal where everybody has to pay out of their pocket." Look, that was the first sentence that he said in his interview. That is the situation,
Yes, sir. So in the part you said technology, so because even we hear in the news that if there are some major burns, those patients tend to be airlifted to India or those nearby neighboring countries. So is it because of lack of technologies or people lacking those trust in the centers that are here? What is your take on that, sir?
I think it is both. Obviously, now India has become a very different country. A lot of us think that India is still poor. No. India has developed financially, economically, like anything. It is going to be one of the, economic giants. I don't have to tell you that, right? That's one thing. And there are certain centers in India where they have developed them as showcase kind of centers, like All India Institute of Medicine. And similarly, there are centers which are physically infrastructure is very decent, and they don't have any dearth of resources in terms of human resource as well as the treatment resource. So in general, in certain centers of India, the standard of care is obviously much better. Okay, that's one thing, especially in those showcase kind of centers. But at the same time, if you look at general India, obviously it's more or less, if you go outside the bigger towns, bigger cities, obviously the condition is not much better than ours. So it depends on which center you are comparing us with. Okay, that's one thing. The other thing is, in India, there are so many burn centers that have come up because of the need as well as the focus on the burn care, development of the burn care from the government side as well. So both the central government as well as the provincial governments, state governments. So they have developed a lot compared to ours. But the need for sending patients with major burns from Kathmandu to India, in some cases it is needful, I think. Not all patients need that, but it depends upon where they are going to go to. Okay, that's also another very important question. They cannot just go to any center. There are many patients who were treated in India and then they were sent home, saying that there is no way you can save you. Just go home, let them die, kind of situation. And then somehow they heard about Kirtipur, especially from the border area. So they have come to Nepal and we have saved them. So, it's both ways. There is another thing I would like to tell you, and that is the story about my visit in Malaysia. Malaysia is much more developed than us, you know that. And when I was visiting their centers, burn centers and other medical centers, they said that many of their patients who are treated there come from Indonesia. The rich people in Indonesia charter their planes and come to Malaysia for treatment. And then I asked the Malaysian doctors, so is there any situation that your rich people also go outside Malaysia? And they say, yeah, of course. There are many rich people, they don't want to be treated by us. They go to Singapore. Okay. And then from Singapore, they go to UK. So that's everywhere, If that happens in Singapore or Malaysia or Indonesia, if some people go out of Nepal for treatment, I don't think we should be discussing that. I can tell you, every time I fly Thai Airlines to go to Bangkok, I see at least several families going there or coming back for normal deliveries in Thailand. Nepalese families going to Bangkok for normal deliveries. So, it depends upon which economic strata you belong to, or what kind of political power you have, or the attention you have, I think. So.
Yeah, because in previous episodes also, our guests were talking about this elitist group of people who are doing more harm because they are trusting less on the healthcare professionals in Nepal, and that has a lot of implications. So, sir, leaving those topics aside, because I think we don't have any control on them, I would like to explore on how was your training per se, right? Starting from general surgery.
Okay. When I finished I was the second batch in the MBBS medical school, second batch. So at that time, there was no postgraduate program in surgery. The only postgraduate programs at that time was the GP, MD-GP, and ophthalmology. There were diploma programs in anesthesia, pediatrics, and OBGYN, okay? No master programs. And so I had to go out of Nepal to become a general surgeon. At that time, the countries like India and few other countries would not recognize us, like UK would not recognize our degree. So we had to go to places like Pakistan or China or Bangladesh. So I opted to go to Bangladesh. I went to Bangladesh mainly because of the fact that one of my teachers was Dr. Bhola Rizal, the famous gynecologist of Nepal. So he knew the director of the institute, postgraduate institute in Dhaka, which ran many different postgraduate programs, including surgery. So that was one factor. And then Dr. Mahesh Kakula was also one of our professors there. So he's, I think, relative. Dr. Lohani was the ambassador from Nepal in Bangladesh. So those were the situation where I had kind of easy way to go to Bangladesh to be registered for the postgraduate program. So I did my general surgery there. But before going there, I had done what they call primary FRCS. At that time, the examination was held in Kathmandu for the first time by the Royal College of Surgeons. And I was one of the three doctors, Nepalese doctors, to pass that exam. Two others were One was from India, a graduate of India, Nepali doctor, but trained in India, went to medical school in India. Another one had gone to medical school in Bangladesh. So three of us, one from Nepal was me. So I had done that, but since there was no other avenue, I had to go there. After I came back, then obviously, after I think 3-4 years of my return, then only the general surgery was started here. So that's how I had to go out of Nepal. Otherwise, if there was a program here, I would definitely have joined that. But becoming a surgeon was my thinking since I was working as a health assistant in a remote area. I was a health assistant before going to medical school, working in a very remote area in Solukhumbu district. Obviously, Solukhumbu is still kind of remote now also. At that time, it was very remote. It took me, I think, 5 days, 7 days to get there. I had to walk. Anyway, so I was working there in a health post, and then a doctor from Okhaldunga, a foreign doctor from Okhaldunga, came there to perform vasectomy through the government program. So the vasectomy camp was in my health post. So obviously, as the in charge of the health post, I was, helping these people. And then the surgeon said, "Oh, why don't you scrub?" So he taught me, the surgery, and then he let me do vasectomy surgery at the end of the trips. And so I was so elated. Wow, this is really nice, because at that time I was able to do a lot of medical things, and I used to help people in many different small surgical conditions, like draining abscesses, setting up the closed kind of fractures, delivering normal kind of delivery, assisting in normal delivery, or at least episiotomy, that kind of thing. I was doing those things. But whenever I used to be called for helping pregnant women delivering a baby, I had to pray to make it normal delivery. That was the situation. So right at that time, I had spoken to myself that you have to become a surgeon one day. If you want to become a Nepali doctor, useful for your people, you have to become a surgeon. That's what I mean, that's not true, obviously. You can be useful as a gynecologist or ENT surgeon. Any doctor is going to be useful. But at that time, because of my young mind, that was the plantation that happened in my mind. So when I came to medical school, right from the beginning, from day one, my mind was in learning all the knowledge and other things like anatomy and a few other things, focused on developing myself as a surgeon in the future. For example, anatomy was the most enjoyable thing for me, and the professor knew that I was so much interested in it. He knew I was a good student, especially in anatomy. So like that, I started preparing myself to become a surgeon. So going to surgery was a natural thing for me.
And since you said there wasn't any MS program in Nepal at that time, how the surgical pathologies used to be dealt with at that time?
At that time, there were no plastic surgeons, obviously, in the whole country. There was one neurosurgeon in the whole country, Dr. Devkota. He had just come back. When I came back as a general surgeon, I'm talking about 1992, he was the only neurosurgeon in the whole country. There was no cardiac surgeon, trained cardiac surgeon. There were a few people who were doing some cardiac surgery, like cardiac surgery or cardiothoracic surgery, like Dr. Yelbi Thapa and Dr. D.N. Gongol. They were performing some, cardiothoracic surgery, but they were not trained, I would say trained kind of cardiac surgeons. But later, Bhagwan Koirala became the first cardiac surgeon, basically. He joined the program as I was coming out of Bangladesh. So I was finishing my general surgery, and he went there to become a cardiac surgery. He entered into the cardiac surgery. So there were no cardiac surgeons at that time. One neurosurgeon, no plastic surgeon, and name all the other subspecialties. There were none. I mean, urologists, for example, there were several general surgeons who were doing urology, but they were not trained as such or qualified with a separate kind of qualification as urology. Of course, they were doing fantastic urological surgeries. It's not that they didn't know urology, but at the same time, there was no MCH urology person in the whole country. So that was the situation. And then I was thinking of going into either neurosurgery or cardiac surgery, because at the university teaching hospital, there were neither of them. But I knew Bhagwan was coming, so he would become the cardiac surgeon. So I was thinking maybe I should go to neurosurgery. But in the meantime, I had a situation where I had to change my mind to become a plastic surgeon.
And for plastic surgery, how was the training, sir?
Well, obviously, in the beginning, there was no plastic surgery program here in Nepal. So in Bangladesh, which was very friendly to Nepal, especially for medical education, they didn't have any plastic surgery program there. So I followed on, and then when they started plastic surgery, then I went there as the second batch of the plastic surgery program there. So I did that. But before that, I had spent 3 years in the U.S. Undergoing fellowship, international fellowship in plastic surgery. I did not do regular plastic surgery residency program there. I was more like an international fellow. I was, since I had USMLE certification, I was able to take calls. I was operating. I was dictating cases. I was posted as like PGY 6, 7, and 8, up to 8, PGY 8 on the third year. So that's how I trained myself. So before going back to Bangladesh to do my master's in plastic surgery, I had already had that experience as a plastic surgery kind of fellow in the U.S. in 2 different places, Dallas and Cleveland.
And if you have to compare your fellowship training in plastic surgery in the US and the master's training for plastic surgery in Bangladesh, what were the different in systems kind of pathologies you deal with?
There is no way we can compare ourselves with the US. The program in the US is so well established, and they have all the requirements for what you are supposed to do in which year, who you are supposed to be supervised by, what are the requirements that you have to fulfill based on the number of surgeries that you have to perform, the kind of surgeries that you have to perform, things like that. It's a very well-structured program there. And there were a lot of research opportunities also. But at the same time, Bangladesh being a country just like Nepal, but they had started the plastic surgery program. In fact, the head of the Department of Plastic Surgery there was a friend of mine. So it was easy for me to get into the program. But anyway, they had started the program, so I had to go there.
And even for fellowship, is it as structured as residency, or is it any different if you go for fellowship, sir?
Yes, because you take the calls, for example, you are operating, you are assisting your seniors, attendings. They don't call consultants, and like in the UK or in Nepal, they call them attendings. So you assist them, you go to outpatient clinic, you run those clinics. At the same time, you also take rounds, you take night calls. So it was basically just like residency, but at the same time, you were not supposed to be qualified as a board certified plastic surgeon. So my training would not let me do board certification in plastic surgery. So it's a training that I got, but at the same time, it was not board certification. So I had to go to Bangladesh to get myself certified as a plastic surgeon.
And the training in Bangladesh, was it 3 years?
2 years. At that time, it was 2 years. In India also, MCS, long time ago, used to be 2 years. So similarly, there also, it was 2 years. But I had this, 3 years plastic surgery exposure in the US, so it was easy for me. In fact, I had learned a lot of things during those 3 years, so it was easy for me to do the 2 years program in Bangladesh. Yeah.
And after completing your master's in plastic surgery in Bangladesh, how was your thought process? How did you think? Because there weren't any plastic surgeons around.
No, Dr. Ishwar Lohani was already there. Professor Lohani was already there, but he was at the University Teaching Hospital, and I had to leave Teaching Hospital around 2003. So, and after I left, but I got Dr. Mathima. He is already deceased now. He was the person who was running the unit, and later Dr. Lohani came back and he started running the unit. So I did not leave it like a vacuum. So Dr. Lohani had just come back, so he was there in the department, and Dr. Mathima was also there. So they ran the program there. So and after that I came out, especially because of the situation that in the period was such that they would allow me to operate only 1 day a week at the University Teaching Hospital. There were so many specialty and surgical subspecialties who were competing for the same operating. There were like 4 or 5 operating rooms at that time. So there were so many specialties, so many units of the general surgery and all. So it was difficult to get the operating time. I was operating 1 day a week. And that there were so many burn patients, and there were so many cleft patients, post-burn contracture, congenital deformities, trauma. There was no way I could finish those cases in time. So the waiting list started getting, long. And I remember the last time I was there, the waiting list was up to 1 year. So if somebody would come today, they would be given a date of operation after a year. I thought that was absurd. And what I did was I took a sabbatical leave of 1 year, non-salary kind of sabbatical leave, and then I organized a program so that I could go to any part of the country to perform cleft lip, cleft palate surgery, and post-burn contracture reconstruction, easy kind of, small congenital malformations. And you may not believe, in 1 year alone, I did over 1,000 operations
in 1 year.
Because I could go to any place, any district, organize my own small team, go there and perform. And there were so many cleft patients at that time, so many post-burn contracture reconstruction cases. So, and then once the year was completed, it was time for me to go back to the teaching hospital. And then I started thinking, if I remain at the university teaching hospital where I can have name and fame, I would do this many operations in about 10 years' time. It would take me about 10 years to do the same number of operations that I performed in 1 year. Then I said, okay, this is the time for me to go out of the system and develop my own program. So that's what I did.
So I think not just me, the entire audience would be more interested in knowing that the entire 1 year where you went to different places in Nepal. I would like to know more about how you assembled the team. You must have done it pro bono. How was the...
No, it was not pro bono, by the way. There were only certain operations which we performed pro bono. The cleft lip and cleft palate operations were supported by Smile Train and Research International. Okay, those were there. So the funding was coming from those organizations to perform cleft surgeries, but post-burn contracture reconstruction and few other congenital malformations. So we were performing, since we were there anyway in the districts or in other, zonal hospitals. And so when patients would come in, we would do them as well because, we didn't want to just cleft, as a plastic surgeon. We like to perform other operations also. So we performed those things pro bono, but at the same time, our stay there was covered. Our travel there was covered. And the medicines and suture materials were used from the stock that we had to do the cleft surgery, actually. So cleft surgery was supported, whereas the others were not, but at the same time we were doing others also. So I was not doing it pro bono. There's no way I can do pro bono. There is not a single month, I have worked pro bono. No. When we go to the other countries to perform surgeries, we go there as volunteers.
Okay.
But not in Nepal. So a lot of people think that, oh, Shankar is great because he did all these things pro bono. No, I have to be honest. No, it's not like that. Even today, at the age of 70, I'm getting salary. So it's nice, getting salary and then doing the kind of work you want to do.
But still coordinating the international funders and talking with the local municipalities or whatever the administrative body is at that time. What was your experience in dealing with this?
At that time, it was easy because the rules and regulations were not that many. For example, right now, if somebody wants to do similar kind of work, you have to go through Social Welfare Council, Ministry of Health, get all the permission, and then only you can do those things. And you got to get the permission from the local authority as well, the local government as well. At that time, it was not like that. We just communicate with the. At that time, also there were some municipalities. We take that permission, but at the same time, it was not like a written kind of thing like we have now. So it was much easier. And at the same time, the team was kept small, just one surgeon or two, and then few nurses, anesthesiologists, and we had all of our things with us, like the anesthesia machines, monitors, and those things, all the sutures and anything, any surgical instruments that we need, everything was carried by our team. And so the team was small in the beginning, but later on when the amount of work started increasing and there was demand from the local communities, come here, there's so many requests, then we had to increase our team. So I started increasing the team with general surgeons. There were ENT surgeons also who could perform cleft surgery. We could teach them. So our team started growing up. So, even today, for example, in our hospital, in a small hospital, 100-bedded facility at Kirtipur, we have 18 attendings. 9 of them are plastic surgeons.
Okay.
And others are reconstructive surgeons like hand surgeons, cleft surgeons. But when there is a need for example, burn patients, if there are large number of patients, and then if we need extra surgeons, all these other people, they join us and they are all trained to take care of the burn patients with us. So that is how we have created the team. So any surgeon who wanted to work with our team, I would never say no to them. Many times I knew that surgeon would not be knowledgeable or skillful in the beginning. It did not matter to me because I knew if we trained them adequately, they would be as good, if not better surgeons than myself. And there has been so many examples right now. There are many surgeons who are much, much better than me, especially cleft surgeons now. We have developed surgeons who are probably the best cleft surgeon of the whole world. How do I know that? Because we invite a lot of international people, including cleft surgeons from all over the world. They come with the intention that they would be teaching our team to do cleft. But when they see how our team members are performing cleft surgeries, complicated cleft surgeries, then they realize, there is no reason for us to go to Nepal and teach them. We would go there to collaborate, okay? Or they would start talking about a higher level of cleft care. Okay, so they don't have to start from bottom. So that is the kind of development of the plastic surgery in general that has happened with our team. So it's a teamwork, as I should say, because without a team, you cannot do work of this magnitude. We have today, as I speak, we have 7 centers outside Kathmandu functioning. They are not functioning every day, but we reach each of these 7 centers, almost every month. We're trying
Could
to
you
expand.
name them, sir?
Yeah. One, for example, from east, Biratnagar, Chiton, Janakpur, and then Pokhara, Nepalganj. These are the centers which are running. And then we have started going to Surkhet and Dhangadi, and we're planning to go to Jumla as well. So the area is expanding. We have people stationed there already. There are several people from our team who are not doctors, obviously, but they are like nurses and other paramedics who are stationed there, who screen the cases before we get there. They take care of, they assist us during the surgery. And then at the same time, after we leave, they take care of our patients post-operative. Many of these people are trained in basic dental care, speech therapy. All of them have learned speech therapy over years. And they also know how to do the physical therapy after the postponed contracture surgery. So the provision of the reconstructive surgery is not only in Kathmandu, it's all over the country in so many different places. But at the same time, the beauty is we're trying to train the local surgeons as well to increase the capacity of those doctors who want to learn from our team. For example, in Janakpur, there is a plastic surgeon already. He's trying to learn more cleft surgery from us. Similarly, there are several other places where the ENT surgeons or maxillofacial surgeons are learning from us. There are several orthopedic surgeons who want to learn hand surgery from us. So, that is the kind of expansion of the service all over the country.
So, and since you talked about data, we know that Kirtipur Hospital is quite active in research, because even in third year we had an opportunity to do research. So how do you balance this clinical and research as well? Are there a dedicated team for research?
Yes, that's a very good question. We have a much bigger team to do the clinical work, obviously, because of the need. But at the same time, we are very interested and concerned about the research that is around the burn issues. And one thing I should stress right now is the reason we do burn research is to solve our problems that are there today. So it's not research for research, it's for solving our problems. For example, the first randomized controlled trial that we started in our hospital was to see what are the difficulties of the oral rehydration solution compared to ringislactate, because ringislactate has to be given IV, whereas oral rehydration solution like Jeevan Gel can be given by anybody. So we're comparing those data. Not that we want to establish it is as effective as ringislactate. That has already been studied in the war field or also in other places. But we're trying to see what are the complexities. So we're doing a randomized control trial. The idea is, a lot of our patients come to us without resuscitation, fluid resuscitation. And fluid resuscitation in the acute burn patients, especially if they have major burns, is so important. Otherwise, these patients would go into what we call burn shock. So to prevent that, we're trying to see whether the patients who are being transferred to Kathmandu in our ambulances without any paramedics would be treated with the oral rehydration solution, and then will it be adequate for that resuscitation? That's what we are trying to see. So that's the first RCT. There are several others which we are conducting right now, and the two other projects which are underway. We usually spend a lot of time preparing the study. It's not like that, okay, let's do tomorrow. It's not like that. We have to prepare several projects over the time. Usually it takes us 1 year to really start from idea to the actual starting the research. It takes us about 1 year. So to do all these things, we have 7 full-time research assistants working with us just in the burn care. So we pay a lot of attention to the burn research, but at the same time, you should understand that these people are getting paid not from the hospital money. I mean, the hospital doesn't have much fund. I mean, we have the problem of providing the basic burn care to our poor patients. Forget about spending your money on the research. But we have been able to collaborate with many international universities and bodies who are assisting us to conduct these research projects, different research projects. Most of them are in collaboration with the Burn Center in Seattle, this University of Washington, and they have several different fellowships also, like Fogarty Fellowship, through which both Nepalese doctors as well as other doctors from international societies, they can apply. And most of our fellows have been from the U.S. itself. So these are international fellows who come and spend a year doing nothing but burn research for a whole 1 year, the 40 fellows. But at the same time, they need a lot of research assistants who are Nepalese. All of them are Nepalese, and they work full-time with us.
And if we have to talk about the outputs from the research, how are they being implemented in other burn care aspects throughout the country as well, not just in your own institution?
It is a difficult question, I think, to answer, because most of our research papers have not been that widely circulated. I know they are being cited by many international people, but we have not been able to spread that among ourselves. That is our weakness. But at the same time, there will be a time when we should be discussing these things among ourselves, because that's more important right here in Nepal. Many of the African countries have been able to learn from our studies. Why not Nepalese people, right? That's a very important question, but I think there is a weakness on our part to disseminate the findings with other colleagues. But at the same time, you must understand that not all the burn centers or burn units in the country are at the same kind of focus on solving the burn issues, because many of the other units are being run by the department, which are busy doing a lot of other things, not just the burn. Whereas in our facility, more than 80% of our patients in the Department of Plastic Surgery are burn patients, whereas in many other units, burn patients constitute maybe 25 or 30 or at the most 50% of the patient's population. So not everybody has to pay equal kind of stress or attention to the new findings that has come up with the research. But we are applying in our facility. Yeah.
Sir, and if someone is interested in burn research like us, so if they want to contact or do any research in Kirtipur Hospital, who should be the person they should contact?
The director of the hospital is a plastic surgeon. He used to be the head of the Department of Plastic Surgery. Dr. Bishal Karki is the present head of the Department of Plastic Surgery. So anybody who is interested, they can drop in. And the best time to drop in is at 8 a.m. in the morning, because from 8 to 9, every day except on Saturday, we have a morning conference where we talk on topical, issues. Certain fellows or attendings or visiting educators are giving presentation every day from 8 to 9. And we also discuss about the patients who are admitted within the last 24 hours, patients who were operated or patients who are being operated on that time. So we discuss those things from 8 to 9. So if somebody comes there at 8, that would be the best time.
And from the perspective of public, so if someone gets burned, I hope it doesn't happen, but if they land up in burns and if they have to come to Kirtipur Hospital, is every expenses covered, or how is the expenditure more?
Yeah, that's a very crucial question. We always wish that nobody has to pay anything for the burn care, because it's an accident. It's not something. If you have cancer, for example, you have some time to arrange your funding. But burns is an emergency kind of situation. There is not much time for you to collect money or borrow money from people. So I think all the burn patients should be taken care of free of cost. That is our idea. But practically, it is not easy. Luckily, the government is helping us to make free for the patients who are really poor. There is a definition of who are poor or who are not from the government point of view. So those patients are taken care of. If patients are poor, especially if they are certified by the local authority, they are taken care of. There are few people who do not who do not come under that radar. The radar doesn't see them, like patients who don't have that kind of certification or card, or patients who are coming from outside Nepal. Right now we have an Indian who needs help. We cannot say that you are an Indian, we cannot help you. So we're taking care of him free of cost as well. So there are certain areas where we have to take care of the patients free of cost, but at the same time, we cannot use the government funding. In those situations, we have other fundings. For example, we have what we call burn endowment fund, where people can donate, and then that money goes to an endowment fund. In Nepali, it's called Achhay Kosh. I'm sure many people know Achhay Kosh. The money cannot be spent, the principal cannot be spent, but the interest or whatever benefit that you can get out of that can be spent on taking care of the patients. There is one gentleman by the name of Ujjwal Bikram Thapa. He is a very, very popular among the Nepalese people. He's a burn activist. He has also initiated burn fund collection. So his fund also is spent on treating many poor patients. We have another arrangement, and that is through a friend of mine who is from Seattle. He's a doctor, so he was born and raised in Canada. Okay. But he moved to U.S. and became a doctor who has been a good friend of mine. And he always advocated that one person should not accumulate a lot of money. And because that creates a disparity in the society, and that is harmful to the health of the individual, health of the nation, and health of the globe as well. That was the teaching that he had been teaching everybody. He's a professor of population health at the University of Washington. And then that's this same person got a lot of money because of the property his parents had in Canada. So he had to sell that property, and he got a lot of money. And he's the person who was advocating not to accumulate a lot of money, and then he had all that money. So he put a lot of his money in the endowment fund in the university so that a professor level person could be paid a salary to teach population health at the University of Washington. And after that, he called me and he said, Shankar, I had this situation, so now I have established this endowment fund for a professorship. I still have some money left, and I'm thinking that I should give that money to you. What would you do with that money? That was the question. I said, I have so many poor patients in Nepal who need help. So your money will be kept in the endowment fund. We're not going to use that money in the endowment fund, and then we'll use only the interest. So he gave me $200,000 US. So that money is also in the endowment fund. So those things we use. But the bad thing is the interest rate has gone down. So that is very painful. But at the same time, we're thinking maybe we should invest in some ways by which the risk of losing money is zero. Like the government bond papers, there you'll get at least 10% or so. It's a government, so you are not going to lose it. So that is what we are thinking. Maybe we should put that money into buying the government bonds so that it is safe. And at the same time, you get a reasonable amount of interest on that. So we do all kinds of different things to collect the money.
So, and in terms of the Kirtipur Hospital, would you call it a tertiary care hospital, or is it a municipal, or is it owned a private partnership hospital? How would you define it?
It's a very good question. A lot of people think that it's a government hospital or it's a private hospital. It's neither a government hospital nor a private hospital. This hospital is being run by a board. The chairperson of the board is the mayor of the Kirtipur municipality, whoever gets elected. And the mayor selects 5 more members from the community, from the municipality. So altogether there are 6 members from the municipality. There is a trust by the name of Public Health Concern Trust. The Nepali name for this trust is Janaswasthya Sarokar Trust. So there are 5 members from the trust. So altogether there are 11 members, but 6 of them come from the local community. That's how the hospital is being run. And the hospital gets funding from the local government, the provincial government, as well as from the central government, a little bit here and there. There is a special arrangement with the municipality so that anybody coming from the municipality to the hospital, they get 50% discount, whereas the municipality provides a fund I think around 70 lakh rupees every year to the hospital. So there's a collaboration between the municipality and the hospital. That's how the hospital basically is being run. It's not a private hospital. It's not definitely for profit making. It's not a government hospital because the doctors and nurses who work there do not get salary from the government. If all these people get salary from the government, the cost could be brought down to very low amount because all of us have to get salary from the money that we generate from the patient's care.
Mm-hmm.
Do you understand what I mean? So if we don't have to worry about our salary, the cost of the care that would come down remarkably.
Mm-hmm. And you must be having a lot of ongoing talks with the government. So is government planning to scale this hospital to a big government tertiary care born hospital?
Yeah, the government has already, the former governments have already recognized this hospital as the tertiary and then at the national level referral center. And then the government in the past have also, they had also announced that this facility will be strengthened to become even larger or bigger facility. The present government is also helping us, trying to help us in many different ways. But at the same time, we have to have a better physical infrastructure. We're thinking of a facility with 100 beds in the same premise. And there is this gentleman from Nepal, whose name I cannot take right now because he has said that he wants to announce that on his own. But he has given us the assurance that he's going to build this 100-bedded facility for us. It'll be physically, it'll be a world-class kind of facility. The main reason why we need a bigger facility is we want to keep patients in individual rooms, irrespective of their financial situation. Patients who come to us without infection, we want to keep them in the individual room, single room, so that they will not get infected from another patient. The infection rate will go down, obviously. There are so many other things by which you can transmit the infection, obviously. Just putting them in the single room doesn't mean that they will not get infection, but it'll be easier, right? And we'll also keep patients who come with infection in the separate room as well, single room. Why? Because their infection should not be transmitted to other patients. So that's what we're trying to do. But obviously, there are so many other things that we have to do in that facility. So it's going to be a much bigger facility than the present facility. In the present facility, we have been with the expansion of the facility now downstairs in the same building. Before we construct the big building, we will have about 50 beds. Right now, we have a total of 38 beds available for the burn patients, acute burn patients. And we already have 36 patients already in the hospital now admitted. So the expansion downstairs will give us a little more number of beds, up to like 50, altogether 50 beds will be available. That should help us for about a year or two, during which time we should be able to start the construction of the bigger facility.
And there is also ongoing MCS program in Kirtipur Hospital, if I'm not wrong. So how is it?
We started the MCS program from NAM's collaboration. Actually, I was the one to write the curriculum for that facility. And then each batch, we had 2 candidates. But now we do not have the MCH, but we have the MEC program.
Okay, NBMS?
Yeah, MEC program. But we haven't got any candidate for the last 2 years, because the number of the people who are applying and qualifying to enter the plastic surgery program is very small. So we're starting discussing about getting candidates right from this medical school, after medical school, because we want to expand the program to 6-year program so that they can do general surgery exposure for a year or 2, and then rest of the year they can spend all in plastic surgery, so that at the end of 6 years they'll be fully trained kind of plastic surgeons. But they will not be qualified in general surgery. Right now you have to qualify as a general surgeon, and then again you have to sit for the exam and to be qualified to enter the program, right? And then at the end we'll have another exam. But now we're trying to have a system by which MBBS candidates can enter the program, and after 6 years they can qualify as a plastic surgeons. So they'll have a degree only in plastic surgery, not in general surgery. So that's what we're trying to get to. MEC had already worked with us to formulate that kind of plan, but before it was planned, the new government came, so the new government is working on that. So we do not know whether the new government would agree to that plan or not.
Is it similar to FCPS program?
It's not FCPS program. It's called NBMS. It'll be more like the curriculum will be just like MCH, but there'll be an additional kind of 1 or 2 years in general surgery. But they do not qualify as general surgeons. They will have exposure in general surgery, just like in the FCPS. But the FCPS was only 5 years program. This is going to be 6 years, because we did not want these people to be inferior to the MCH people, because MCH people will have 6 years altogether. So if they have only 5 years, then obviously the MCH people will say, okay, you are inferior to us because your training is only 5 years. So not to get into that kind of problem, we want to make that course 6 years. But the present government will have to okay that program.
So that brings me to the next question, because like you said, there have been no NBMS candidates for the past 2 years. And if you had to shed some light into the evolution of this plastic surgery in coming days, so that young trainees like us, we will be more informed, so that we can have this informed decision making whether to go into plastic surgery or not. How would you say this field is evolving? Like you said, the oncological reconstruction is increasing. Burn, how will the burn epidemiology be changing? The cleft lip and palate, those congenital anomalies will be changing.
I hope that the incidence of burn will be less and less as we can provide more electricity throughout the country, especially at a very small price, okay? Because that has been the situation in all the developed countries. But it's going to take some time. And at the same time, the cleft lip and cleft palate, the number of the births in Nepal, the rate of birth is coming down. So you'll have less number of clefts. But at the same time, there are more people who are trying to undergo cosmetic surgery. So you can train yourself in cosmetic surgery while doing reconstructive surgery. The trauma, infection, and tumors, the post-cancer reconstruction, those are always there. And then probably some of the incidents will be even more, especially the trauma, for example, with the increasing number of roads all over the country, more vehicles, and I think the trauma is not going to be decreasing in the near future. Whereas the burn incidents will go down after, like, at least the time when we have to wait for the electricity authority to provide more electricity at a low cost. So that's going to happen. So I think you'll be busy. I mean, coming to plastic surgery, I don't think if you have done general surgery already, it's easier for you because you'll just have to undergo 3 years of further training, and then seats are there all the time. If you qualify, it's always there, because for the last almost 4 or 5 years, we have less number of candidates than the number of the positions that are there. There was a time when there were few positions and then more people competing for the same position, but the situation is not like that anymore, especially if you are already a general surgeon. And we are still trying to wait for the government to okay our program for 6 years. So that will bring in more younger people into plastic surgery, we hope, because the number of people who are applying will be much, much higher compared to the number of general surgeons who are applying for plastic surgery. There will be thousands of MBBS people applying for the postgraduate program, whereas there are only few, like 3, 4, 5 people apply for the plastic surgery after they become general surgeons. So there will be a manifold, increase of the people who are competing for the plastic surgery if we open the door for the MBBS people.
And do you think this new change will be implemented shortly, or will it take time?
I do not know, because the new government has to decide whether it sees the importance of having this kind of program, because it's not just plastic surgery, it's also for neurosurgery, for cardiothoracic surgery, and also for, I think, oncological surgeries, because these specialties, subspecialties are also not getting enough people into the system. So 3-4 different subspecialties, I would say, are trying to get into this system. So we were together with MEC in the past with the older government. We're there. We have discussed so many times about this, and then everything was prepared, and then it is already submitted to the government. So it's up to the government now whether they want to go with this new plan.
Because even for me, our younger graduates, like, we think if we really want to go into some specific specialty or subspecialty within surgery, why not? If there is some program like FCPS or like the one you mentioned, why not we devote our time in that and be trained in that and keep on doing that for the rest of our life? So, sir, I think we have talked on a lot of topics which I wanted to explore from you, and there have been a lot of lessons. And before concluding, there are few questions which are regarding your personal experience in this entire field of surgery or plastic surgery. So if you had to shed light on some rewarding moments that have been in your professional career, I'm sure there must have been a lot, but if you have to mention a few rewarding moments, what would them be?
Well, as I told you earlier, patients' family who had lost their family in the hospital, they're coming back with more patients. That's amazing to me. That's really kind of them to understand the difficulties of the medical care. That's really rewarding. And then another thing was when I received that American award, I was really surprised because I had not contributed anything to the American healthcare, and they were recognizing me. And there were many Nepalese who were working in the US, and they were not in the list. I'm in Nepal working, for the poor people in Nepal, and I was the one to get that. So that was surprising to me. And then the way our team members, even though they are getting small salary and still working so hard, I think that is a moment that keeps me smiling all the time. And that is the energy that gets me up every morning and makes me go to hospital every day and to be with them, with these young people who should be aspiring, like their other colleagues who are making, enough money. But at the same time, these people, they're there smiling in spite of getting, minimal salary and devoting that time for the care of poor people. I think that's the moment when I keep on smiling all the time. Yeah.
And most challenging case of yours, sir?
There are many, I would say. For example, just last week, only a few weeks ago, there was this patient with 85% burn. And the patient was airlifted from Tarai, Sarlai, and there were phone calls from all over. The health minister, the prime minister's office, the health secretary, and even a politician were requesting us to take care of that patient and then do everything that is possible to save that patient. And we knew 85% burn would not survive in Nepal. The largest percentage of the burn that we have been able to save so far is 60%. And this patient had 85%. So, but we had to do everything. But at the same time, all of us in Kirtipur Hospital know that no miracles happen in burn care. There are many miracles that happens in your life, in daily life, non-medical life, or even in medical field. For example, you must have heard of patients who had untreatable cancers like stage 4. Cancer has spread all over somebody's body, and then after 6 months, there is no evidence of cancer. And now we know the explanation because that happens because of the immune mechanism, right? That's a miracle. We have yet to see a single miracle in burn care.
Mhm.
Do you understand what I mean? For example, there was a time when we are not able to save any patient with 40% burn. We save 50% of those patients now after 10 years of hard work. But that is because of the hard work that we have put for 10 years. That would not happen in 6 months or 1 year. Saving not a single patient with 40% burn and saving 50% of those patients in 6 months' time. That does not happen. It takes such a long time. So these are the difficult moments for us because you have to wait. We have to learn more. You have to train yourself. You have to have access to the technology slowly. All these technologies are prohibitively expensive. There's no way our poor patients can access those technologies. So those are the things that are painful for us, especially our limited access to the technology that are there, which are available without any question, without even thinking in the developed countries. Whereas here, but you should understand that even if we are given all the resources that they have in the developed countries, we won't be able to save 50% of the patients with 92% burn. Okay, you must understand that. It's not just the lack of the funding, but at the same time, the lack of the system that we have to develop, the lack of knowledge and skills, especially in the critical care. Critical care in the burn is very, very important. As surgeons, we can operate, you can excise, you can graft, but that is not enough in the burn care. You need burn critical care specialist, and that is most difficult in the developed countries like ours. Even in India, there are very few people who are trained as surgical critical care specialists. That is what you need for the burn patient, especially if they have major burns. So, those things are the challenges we have.
And sir, a few rapid fire questions for you. Who was your role model while you were younger, sir?
While young, I had my teachers in the school, or who would be accessible any time of the day and night. It was a small school. The teachers had their families, but we could go to the room any time of the day or night, any day, and ask them questions. I could not solve this problem, mathematics or something, and can you teach me? They would not say no to any students. I think that is very unusual. I think I remember that all the time. Yeah. So my teachers. Yeah.
And I think you imbibed that philosophy and transferred it to the Kirtipur Hospital so that any patient can come to the door of Kirtipur Hospital and ask for the...
Yes, thank you.
Sir, if it was not surgery, I think this may be out of the blue question, but if it was not surgery, what would be the profession you would pursue?
No, when I was in school, like 10th grade, I was not even thinking of going to a medical school. Initially I was thinking of agriculture because I had already applied for that. After SLC, we had SLC at that time. I had first division in SLC, and I was thinking of going to agriculture. But during that, there was a system by which we could go to India for 6 years after SLC, and you could come back with BSc degree.
Okay.
And that was what I had applied for. But that was the year they cancelled that Colombo plan. They used to call it Colombo plan. So I could not go to agriculture. Okay. And then I was thinking of going to engineering. In Pulchok, I knew that was the engineering campus. And then every time I would pass through that road, I would greet that building saying that one day I'm going to come here and study engineering. But as I was about to apply for the school, for the engineering school, my father said, "No, you cannot go to engineering because I heard the students there have to carry loads of bricks and sand and cement. You cannot do that. Look at your physics. You cannot do those things, physical things." So he said, "You should go to become a doctor. You should go to health." I said, "Sure, I will," because I was an obedient son. So the situation now is not like that. You cannot ask your children to become anything these days. They have their own choices. But I'm lucky that my son is a plastic surgeon and he wants to devote all his time in the care of burns. I'm lucky, but I cannot ask him to do so. If I have to ask him, I cannot. But he chose it on his own. That's a different thing. So, forget about surgery. I was not even thinking of medicine in the beginning.
Yeah, and I had chance to meet with your son during the
Okay.
duties as well, sir. And you have done a lot of humanitarian and international global surgery work, especially in plastic surgery. Which was the country you liked the most? There must be a lot.
Oh, there are so many of them. The country I have been to so many times is Vietnam. I've been there like 8, 9 times. I've been to South American countries like Peru and Ecuador several times. The need is always there. Even in, for example, Peru, Lima is the capital there. If you look at their hospitals, there are plastic surgeons, but they pay attention to only the cosmetic surgeries. They don't want to do cleft, they don't want to do burns. That was very painful to me because they were there, but they would not take care of their patients with reconstructive surgery. Even in Vietnam. But there were other people who were trying to learn. There were like orthopedic surgeons who were trying to learn plastic surgery. There were maxillofacial surgeons who wanted to learn cleft. So there are always people who want to learn. So I think Vietnam is a place I would like to go back again. I mean, because of my age, I cannot because I'm already 70. There are health issues by the time you get to 70. So I cannot travel much these days, and I cannot stay there for 2 weeks because most of these missions are for 2 weeks. So I cannot go there anymore. But that is one thing I really miss, going out and working for those people there, the poor people there.
So how did this international work change your perspective?
It gives you the vision that the work that you are trying to develop in your own country is so much needed in other countries as well. The way we have leveraged the funding that we get from the international organizations, the same way somebody in those countries could also leverage the funding that they could get from international or the government funding, and they could provide a fantastic reconstructive surgical care there. So I have difficulty seeing those things in many developing countries because the plastic surgeons want to focus only on cosmetic surgery. That's not here in Nepal, at least. Most of the plastic surgeons in Nepal, they do not focus only on cosmetics. There are exceptions, 1 or 2 exceptions in Nepal. Otherwise, almost all of us do reconstructive surgery on top of the cosmetic surgery, which is really good. I think there should be a combination of both. I don't ask any plastic surgeon just to devote only on the reconstructive surgery. You should enjoy doing cosmetic surgery. The procedures are very enjoyable. You can see the changes, but at the same time, you make some money as well. It makes your life easier probably. So that is also important. But at the same time, the need for the reconstructive surgery outweighs the need for the cosmetic surgery.
And book that has influenced you the most?
There are many books, I would say. There is one book I really remember, The Road Less Traveled. You have heard of that book?
I have heard of the poems, Robert Frost.
Okay. This is the book written by a medical doctor. I think everybody who is going to be a parent, a father, a mother, should read that book. I read that book, but I was not able to implement everything during my fatherhood or parenthood. But I wish I could apply a lot of those knowledge in raising my children. They were raised mainly by my wife, who was taking care of them, hampering her education. But I was very much involved in the work I was doing, so I was not able to give them the kind of care I should have provided. I feel bad about that, but luckily both of them did very well in education. My daughter is an architect. My son is a plastic surgeon. So both of them did well, but at the same time, I wish I had spent more time with them when they were growing. So please read that book, The
Yes.
Road Less Traveled.
So I think this is the story we hear lot of from the accomplished surgeons, that when they had to devote their time to work because the work is demanding, they have to make some trade-offs in their personal or family life. So can the new generations balance this both, or you should be?
I think I see the trend that the younger people are paying more attention to their family, which is a very good thing. I mean, I would not suggest anybody to compromise the family relationship for any kind of good work that you are doing. I don't think you have to compromise your family thing for any good work. You can always do the good work balancing your family. I think I always see that. I could not apply that knowledge, obviously, as you can see, but the trend today is much different. Younger people, younger surgeons, younger doctors are spending more time with their family, which is a very positive trend, I think.
And so almost we are to the end. So if there had to be one specific suggestion for the people who are in the pre-medical phase of their life and in medical school and who have been just out of medical school, what would that one specific advice be for these three groups?
I think the best thing is to find what their inner self wants. Okay, do not flow with the wind. There are a lot of things that are influenced. The influences come from your peer groups and media and things like that. But please listen to yourself. Many times people are so engaged that they cannot even listen to themselves. Listening others is important, but listening oneself is even more important. And I would suggest them to do that, which means sit down and then talk to yourself. What is the best thing that you enjoy doing? What is the best thing that you want to do? In spite of all the other situations, there many times your situation may not be allowing you to do what you want to do, and you have to compromise. I think please listen to your inner self. That should guide you rather than the wind, rather than the trend, rather than what your relatives or your friends, your peer groups are telling you, I think.
Thank you, sir. Any concluding remark you had?
No, thank you very much for inviting me. This is a great opportunity because this is the first time I think I'm talking for the purpose of the younger people, especially people who are going to be doctors or people who are in medical school or in the early period of their medical or surgical career. This is a fantastic opportunity. Thank you very much.
Thank you, sir. So I would say Kirtipur Hospital, despite it started from low resources, I would say, or from the thought of Dr. Rai trying to do more for the burn patients, even trying to do more with less. Now it has been an exemplary state-of-the-art example for the burn patients in Nepal. And like how he shared, in the decades after decades of hard work, the team has really been successful in improving the burn care, not just talking anecdotally, but talking with the data and all the research evidence that the hospital has. So I think it will be a very motivating story and exemplary example of how a person with his inner desire and the teamwork he has built and an ecosystem he has built can do for the even complex condition like burn, where you are fighting against all the odds. The system is not favorable for the care, and I think it is really a motivational story for us, and I'm always inspired by your humility, sir. Thank you again for joining us, sir.
Thank you very much, sir. Thank you.
Namaste, sir.
Thank you.